Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
A thorough understanding of the central nervous system modulation is essential, especially when discussing central nervous system excitation and the medications used to manage it. This curriculum delves into the complex balance of key neurotransmitters such as gamma-aminobutyric acid and glutamate. These neurotransmitters are crucial for understanding neuronal activity and inhibition. Next, we explore the important application of this knowledge in rapid sequence intubation, emphasizing the main goals of achieving profound central nervous system depression for patient safety and procedural effectiveness. The content systematically investigates the key factors that influence the selection of induction agents. These factors include patient-specific characteristics, hemodynamic considerations, airway management, and underlying medical conditions. Furthermore, we provide a detailed examination of commonly used agents, including etomidate, ketamine, propofol barbiturates, and midazolam. Each agent's unique pharmacological profile, clinical utility, and potential challenges are highlighted. Special attention is given to the ongoing comparative analyses between etomidate and ketamine, particularly concerning their respective effects on hemodynamic stability and patient mortality. This reflects the evolving nature of evidence-based practice in critical care. It is essential to foster a deep understanding of central nervous system modulation and the judicious application of pharmacological agents for rapid sequence intubation. Upon completion of this curriculum, learners will be able to describe the fundamental roles of gamma-aminobutyric acid GABA and glutamate as the primary inhibitory and excitatory neurotransmitters, respectively, in the central nervous system. This description should include details about their synthesis, metabolism, and receptor subtypes. Students should also be able to articulate the primary goals of inducing profound central nervous system depression and sedation during the rapid sequence intubation process. Emphasis should be placed on patient awareness and the facilitation of successful endotracheal intubation. Furthermore, learners will need to identify and explain key patient-specific characteristics, underlying medical conditions, and pharmacokinetic and pharmacodynamic properties that critically influence the selection of an induction agent for rapid sequence intubation. In addition, students will describe the pharmacological properties of etomidate, including its mechanism of action, typical dosing advantages, and common adverse effects as an induction agent. They should explain the mechanism of etomidate-induced adrenal suppression, discussing the ongoing debate about its clinical significance, as well as current recommendations for prophylactic corticosteroid administration. The curriculum will also cover the pharmacological properties of ketamine as an NMDA receptor antagonist. Learners will explore its mechanism of action, typical dosing, and unique clinical benefits, which include its hemodynamic profile, analgesic properties, bronchodilator effects, and neuroprotective qualities. Students will differentiate between etomidate and ketamine, focusing on their respective impacts on hemodynamics, adrenal function, and the current evidence regarding mortality and other patient-centered outcomes in critically ill populations. Moreover, the pharmacological properties of propofol will be discussed, along with its benefits such as intracranial pressure reduction and bronchodilation. However, significant limitations will also be addressed, particularly its profound hypotensive effects that necessitate caution in hemodynamically unstable patients. A summary of the historical context, mechanism of action, and current clinical considerations for barbiturates, such as methotrexate and midazolam as induction agents for rapid sequence intubation, will be provided. This will include their side effect profiles and reasons for their diminished use in contemporary practice. Finally, students will apply their knowledge of the distinct pharmacological profiles and patient-specific considerations of various induction agents. They will evaluate and propose an appropriate agent choice for rapid sequence intubation in diverse clinical scenarios, referencing current guidelines and evidence. It is essential to comprehend the complex balance of neurotransmitters within the central nervous system. This understanding is particularly crucial when engaging in discussions about central nervous system excitation and the manner in which different pharmacological agents can modulate this excitation. Central nervous system excitation is characterized by a state of increased neuronal activity in the brain. This heightened activity is significantly influenced by the interaction between excitatory and inhibitory neurotransmitter systems. The equilibrium between these systems plays a vital role in determining the overall state of excitation within the central nervous system. Gamma-aminobutyric acid, commonly referred to as GABA, serves as the primary inhibitory neurotransmitter in the brain. It plays a crucial role in mediating both presynaptic and postsynaptic inhibition. GABA is synthesized at nerve endings through the decarboxylation of glutamate, a process that relies on the enzyme glutamate decarboxylase, or GAD. Once formed, GABA is transported into secretory vesicles by a specific vesicular GABA transporter. The metabolism of GABA occurs mainly through transamination, resulting in succinic semialdehyde and subsequently converting to succinate within the citric acid cycle, a reaction catalyzed by GABA transaminase. Following the release of GABA from a neuron, a high-affinity GABA transporter facilitates its uptake back into the neuron. Researchers have identified 3 subtypes of GABA receptors: GABA-A, GABA-B, and GABA-C. The GABA-A and GABA-B receptors are widely distributed throughout the central nervous system, whereas GABA-C receptors are predominantly located in the retina. Both GABA-A and GABA-C receptors function as ionotropic receptors. When activated, they permit the entry of chloride ions into neurons, which mediates fast inhibitory postsynaptic potentials. In contrast, GABA-B receptors are classified as G-protein-coupled receptors, or GPCRs. These receptors are linked to changes in potassium and calcium ion influx through G-proteins. The GI protein inhibits adenylyl cyclase, leading to the opening of a potassium channel, while the GO protein inhibits or delays calcium influx. Thus, the activation of GABA receptors mediates both presynaptic and slow postsynaptic inhibition. GABA-A receptors are composed of 5 subunits, which include various combinations of 6 alpha subunits for beta, for gamma, 1 delta, and 1 epsilon. This composition gives rise to distinct properties of the receptors based on their location within the nervous system. Benzodiazepines enhance the conductance of chloride ions induced by GABA-A receptors. Additionally, barbiturates have proven to be effective anticonvulsants, as they enhance GABA-A receptor-mediated inhibition while simultaneously suppressing excitation mediated by AMPA receptors. Glutamate serves as the primary excitatory neurotransmitter in both the brain and spinal cord. It accounts for approximately 75% of excitatory neurotransmission within the central nervous system. There are 2 main pathways involved in the synthesis of glutamate. In the first pathway, alpha-ketoglutarate, derived from the Krebs cycle, is converted into glutamate through the action of the enzyme GABA transaminase. In the second pathway, glutamate is released from the nerve terminal into the synaptic cleft via a process known as calcium-dependent exocytosis. After its release, glutamate is transported into glial cells using a specific glutamate reuptake transporter. Within the glial cells, glutamate is transformed into glutamine by the enzyme glutamine synthetase. The glutamine then diffuses back into the nerve terminal, where it is hydrolyzed back into glutamate by the enzyme glutaminase. Additionally, a membrane transporter is responsible for returning glutamate directly to the nerve terminal. Within glutamatergic neurons, synaptic vesicles are capable of highly concentrating glutamate through the action of a vesicular glutamate transporter. Glutamate interacts with both ionotropic and metabotropic receptors found in the central nervous system. There are three subtypes of ionotropic glutamate receptors: EMPA, kainate, and NMDA receptors. These receptors are tetramers that are composed of different subunits. When AMPA or kainate receptors bind glutamate, they primarily facilitate the influx of sodium ions and the efflux of potassium ions. This process results in a rapid excitatory postsynaptic potential. The activation of NMDA receptors allows for the influx of both calcium and sodium ions. The binding of glycine to the NMDA receptor is crucial for the receptor's response to glutamate. When glutamate binds to the NMDA receptor, the channel opens. However, magnesium ions block it at standard membrane potentials. This block is removed only when the neuron experiences partial depolarization due to the activation of adjacent AMPA and kainate receptors. Consequently, the excitatory postsynaptic potential induced by NMDA receptors is slower compared to that induced by AMPA and kainate receptors. Activation of metabotropic glutamate receptors increases the levels of intracellular inositol 1,4,5-triphosphate and diacylglycerol, or it may decrease intracellular cyclic adenosine monophosphate levels. The brain possesses 8 known subtypes of metabotropic glutamate receptors, which can be found at presynaptic or postsynaptic sites. These subtypes may play a role in synaptic plasticity within the hippocampus and cerebellum. Furthermore, the activation of presynaptic metabotropic glutamate receptor autoreceptors on hippocampal neurons can limit the release of glutamate. NMDA receptor antagonists are utilized in the treatment of chronic pain. Additionally, mGluR5 is being explored as a target for drug development aimed at addressing neuropsychiatric disorders. The balance between GABAergic inhibition and glutamatergic excitation is vital for normal functioning of the central nervous system. In critical care settings, particularly during rapid sequence intubation, the goal is to safely induce a state of profound central nervous system depression. This approach facilitates intubation and helps to prevent adverse physiological responses. GABAergic drugs enhance inhibition, effectively blocking neuroexcitation. In contrast, ketamine produces a different state of central nervous system alteration, commonly referred to as dissociation. This occurs by antagonizing excitatory glutamate receptors. The clinical decision on which agent to use often depends on the patient's hemodynamics and specific requirements. For example, Etomidate is preferred due to its stability with regard to hemodynamics. It decreases cerebral metabolic demand and intracranial pressure while preserving cerebral perfusion pressure by stimulating GABA receptors. However, Etomidate does not possess analgesic properties. As a result, unmitigated painful stimuli can still provoke neuroexcitation. On the other hand, ketamine provides both sedation and analgesia. Its sympathetic effects can help maintain blood pressure, making it a suitable option for patients who are hypotensive. Additionally, ketamine has been shown to reduce neuroexcitation. In summary, whether through enhancing the inhibitory GABA system or blocking the excitatory glutamate system, induction agents strategically manipulate central nervous system activity. This manipulation achieves a controlled state of unresponsiveness, which is critical for effective and safe airway management. Other neuroactive substances such as glycine, acetylcholine, norepinephrine, epinephrine, dopamine, and serotonin also play significant roles within the central nervous system. Each of these substances can contribute to the induction process. However, a comprehensive discussion about them is beyond the scope of this topic. Future discussions on sedation and analgesia and seizure control can address these additional components. The primary goals of sedation during rapid sequence intubation are to ensure that the patient remains unaware of the procedure and to facilitate a successful endotracheal intubation. Sedation and analgesia are essential during invasive procedures, including endotracheal intubation. It is important to administer a sedative or induction agent when giving any neuromuscular blocking agent to patients who show any level of clinical responsiveness, such as reactivity to noxious stimuli. Various factors play a role in determining the appropriate induction agent for procedures like rapid sequence intubation. These considerations encompass patient-specific characteristics, underlying medical conditions, and the pharmacokinetic and pharmacodynamic properties of the available drugs. Hemodynamic factors play a significant role in determining the appropriate induction drug for patients. Etomidate is often considered for those who are at risk for hypotension or myocardial ischemia. This is due to its minimal cardiovascular effects, which make it a safer option in these cases. However, it is important to note that etomidate is associated with an increased risk of adrenal insufficiency. This condition can have detrimental effects on hemodynamic stability. For patients with asthma or for children undergoing brief and painful procedures, ketamine may be the preferred choice. Ketamine typically induces cardiovascular effects that resemble sympathetic nervous system stimulation. This results in increased blood pressure, heart rate, and cardiac output, thus offering favorable hemodynamic conditions as an induction agent. Additionally, propofol is advantageous for procedures where it is important for the patient to return quickly to a preoperative mental status. It may also be the preferred induction agent for patients with asthma because of its beneficial bronchodilator properties. Nonetheless, one must consider that propofol can lead to decreases in systemic blood pressure and may have a negative inotropic effect, potentially resulting in bradycardia. Inhalational techniques are generally not recommended for managing difficult airways in critically ill patients. This is because such techniques can lead to a slow and challenging induction, which may be further complicated by upper airway obstruction, hypoxemia, and hypercarbia. When it comes to managing the induction of anesthesia in patients with asthma, selecting the right agents is vital. It is important to choose medications that minimize the risk of bronchospasm and respiratory depression, while also taking into account any potential interactions with asthma medications. Propofol is a noteworthy option, as it is less likely than barbiturates to provoke bronchospasm. In fact, propofol may be the preferred induction agent for patients with asthma due to its bronchodilator properties. However, one must be cautious, as some formulations of propofol contain a metabisulfite preservative, which may lessen these beneficial bronchodilator effects. Ketamine is another effective choice, being a potent bronchodilator. This makes it particularly suitable for anesthetizing patients who are at a high risk for bronchospasm. The respiratory effects of ketamine strongly indicate its use in this patient population. In contrast, barbiturates tend to produce a greater incidence of wheezing in asthmatic patients when compared to propofol. This increased wheezing is likely due to histamine release from mast cells during the induction process. Desflurane also has bronchodilator properties. However, it is a strong airway irritant. Consequently, it can induce coughing, breath-holding, laryngospasm, and excessive respiratory secretions. Due to these irritant qualities, desflurane is not typically used as the primary anesthetic for the induction of anesthesia. The underlying medical conditions and associated risks of the patient play a crucial role in the selection of an appropriate anesthetic agent. For instance, when considering asthma, ketamine is particularly well suited for anesthetizing patients who are at high risk for bronchospasm, thanks to its bronchodilator effects. In the context of seizures, etomidate may pose an increased risk for patients with epilepsy as it produces elevated electroencephalogram (EEG) activity in epileptogenic foci. When selecting an induction agent for rapid sequence intubation in patients with elevated intracranial pressure, it is essential to choose an agent that either lowers intracranial pressure or, at the very least, does not increase it while ensuring adequate cerebral perfusion pressure. Propofol is a suitable option for this purpose, as it decreases intracranial pressure. A study involving 6 patients with head injuries demonstrated an average decrease of 14 millimeters of mercury in intracranial pressure following the administration of a bolus of propofol for induction. Barbiturates such as methotrexate also decrease cerebral metabolic oxygen demand, intracranial pressure, and cerebral blood flow. However, caution is advised in using this agent for patients with traumatic brain injuries due to its potential to induce hypotension. Etomidate is another agent that lowers intracranial pressure and has minimal cardiovascular effects, making it a commonly used induction agent for rapid sequence intubation. This medication can lead to a decrease in cerebral blood flow by 20 to 30%, resulting in a moderate reduction of intracranial pressure that can persist for several minutes. Nevertheless, care must be taken, as etomidate may increase the risk of seizures, as previously mentioned. Historically, ketamine was avoided in patients presenting with increased intracranial pressure due to concerns regarding its effect on cerebral oxygen consumption, cerebral blood flow, and intracranial pressure. Nonetheless, recent studies have indicated that in sedated and mechanically ventilated patients, ketamine does not elevate intracranial pressure. It has emerged as an excellent option for an induction agent in patients with blunt head injuries, supported by data that highlights the association of hypotension with increased mortality in this particular population. Lidocaine has been employed to mitigate the sympathetic response to intubation in patients with suspected elevations in intracranial pressure. It was believed to function through a combination of suppressing reflexes, inducing peripheral gamma-aminobutyric acid receptor anesthesia, depressing the brain stem, slowing cerebral metabolism, and stabilizing membranes. However, some experts contest this viewpoint, suggesting that the practice may cause more harm than benefit. Furthermore, some studies indicate that intracranial pressure still increases in patients receiving lidocaine, albeit more modestly. Considering these factors, propofol and etomidate emerge as reasonable choices for induction in patients with elevated intracranial pressure. While the use of ketamine was once contentious, recent evidence suggests that it may be safe for use in sedated and mechanically ventilated patients. The shock index is calculated by dividing the pulse rate by systolic blood pressure. It can be a useful tool in identifying patients who are at risk of experiencing adverse hemodynamic changes following the induction of ketamine. Patients with a high shock index, defined as being equal to or greater than 0.9, are more prone to hypotension after ketamine induction. A study indicated that 26% of individuals with a high shock index develop hypotension after the induction, while only 2% of those in the low shock index group experience similar outcomes. Additionally, patients with a high shock index show a blunted hypertensive response to ketamine. While individuals with a low shock index typically experience an increase in systolic blood pressure after ketamine induction, those with a high shock index do not demonstrate the same increase. Furthermore, these same patients may have a delayed and limited compensatory acceleration of the heart rate compared to their low shock index counterparts. Conversely, patients with a low shock index, which is defined as being less than 0.9, tend to maintain sustained increases in both pulse rate and systolic blood pressure after the induction of ketamine. A significantly larger proportion of individuals within this group, approximately 40%, become hypertensive in comparison to the 13% of high shock index patients who experience similar effects. The hypotension observed in individuals with a high shock index following ketamine induction may be attributed to depleted stores of catecholamines. The mechanism of ketamine relies on the release and reuptake inhibition of these catecholamines. Therefore, if these stores are diminished, ketamine's ability to ensure hemodynamic stability could be compromised. It is advisable to identify patients who are at risk for hypotension or hypertension when ketamine is utilized as an induction agent. This involves an assessment of the frequency of these events. Consequently, consideration may be given to reducing the dose of ketamine for patients at risk of hypotension or to administering additional opioid medications in cases where hypertension is likely to occur. Optimal pharmacokinetic properties for all rapid sequence intubation medications include a rapid onset and a short duration of action. Parenteral anesthetics exhibit these properties due to their lipophilicity and the high perfusion of the brain and spinal cord. As a result, they generally provide a rapid onset and a short duration after a single bolus dose. Ketamine, with its large volume of distribution and rapid clearance, is particularly suitable for continuous infusion. When considering other factors, potential side effects are significant. It is essential to balance a patient's pathophysiology with the side effect profiles of drugs when selecting an inhalational anesthetic. For instance, propofol can cause pain upon peripheral administration. This discomfort can be mitigated by administering lidocaine using a larger peripheral vein or opting for central venous administration. Additionally, etomidate may lead to myoclonic movements, nausea, vomiting, and adrenocortical suppression. Drug availability is another important consideration. Drug shortages can severely limit the options available for selecting the most effective drug regimen for rapid sequence intubation. Thus, it is crucial to evaluate alternative combinations of induction agents or neuromuscular blocking agents when the ideal choice is unavailable. Rapid sequence intubation is often necessary for patients at an increased risk of pulmonary aspiration. This includes individuals with bowel obstruction, those who have undergone esophageal surgeries, patients with ascites, and those experiencing small bowel obstruction. Therefore, selecting an induction agent requires a comprehensive evaluation of the patient's condition, potential risks, and the specific properties of the available medications. Etomidate is a widely discussed induction agent in the context of rapid sequence intubation for critically ill patients. It is often compared with ketamine because of their similar effects on the cardiovascular system. The literature extensively covers its utility, advantages, disadvantages, and the ongoing debate surrounding its use. Etomidate is a sedative hypnotic agent derived from imidazole. It induces unconsciousness by stimulating gamma-aminobutyric acid receptors. This agent is characterized by a rapid onset of action that occurs within 30 to 60 seconds, accompanied by a short duration lasting approximately 5 to 10 minutes. For rapid sequence intubation, a typical induction dose ranges from 0.2 to 0.3 milligrams per kilogram. In hemodynamically unstable patients, it is advisable to reduce the dose to 0.2 milligrams per kilogram and adjust the dosage according to body weight in individuals who are morbidly obese. One of the key advantages of etomidate is its minimal effects on cardiovascular function. It generally does not significantly alter heart rate, blood pressure, systemic vascular resistance, or mean arterial pressure. This makes etomidate a preferred choice for patients experiencing left ventricular dysfunction or those who are hemodynamically unstable. Furthermore, it is considered to have a protective effect on the brain. It reduces intracranial pressure, decreases cerebral blood flow, and lowers cerebral oxygen consumption while preserving cerebral perfusion pressure. Despite its benefits, a notable limitation of etomidate is its lack of analgesic properties. Common adverse effects of this agent include myoclonic jerks, which can sometimes be mistaken for seizure activity, and pain at the injection site. This pain is often attributed to its propylene glycol diluent. When administering induction agents, there are notable differences between using weight-based doses and fixed doses. These distinctions can significantly impact the efficacy and safety of the medications involved. Weight-based dosing refers to the practice of calculating the medication dose according to the patient's body weight, expressed in milligrams per kilogram. This method allows for a more personalized dosage, as it takes into account variations in factors such as volume of distribution, clearance, and other pharmacokinetic parameters among different patients. For instance, propofol is typically administered at a dose of 1.5 milligrams per kilogram intravenously in healthy patients. In the case of obese individuals, actual body weight is utilized for dosing. Etomidate is usually given at a dose of 0.3 milligrams per kilogram. However, this may be adjusted to a lower dose of 0.2 milligrams per kilogram for patients who are hemodynamically unstable. Ketamine is generally administered in a range of 1 to 2 milligrams per kilogram. The benefits of weight-based dosing include the ability to achieve optimal drug concentrations, minimizing the risk of underdosing or overdosing, and ultimately improving clinical outcomes. In the case of obese patients, it can often be more effective to use lean body weight instead of total body weight when determining initial loading doses. Fixed dosing refers to the practice of administering the same dose of medication to all patients, without consideration of their individual characteristics such as weight. This method simplifies the process of medication administration and decreases the risk of calculation errors. For instance, Etomidate may be administered as a fixed dose of 20 milligrams. However, there are notable drawbacks to this approach. Fixed dosing does not take into account the significant variability in pharmacokinetics and pharmacodynamics among different patients. Consequently, this can result in drug concentrations that are either subtherapeutic or potentially toxic for certain individuals. General considerations must take into account various patient-specific factors when determining the appropriate dosing strategy. These factors include age, organ function, and the concurrent medications that a patient may be taking. Each of these elements can significantly influence the decision to use weight-based versus fixed dosing. Furthermore, the clinical context in which the treatment is provided plays a critical role in dosing decisions. The urgency of the situation and the availability of monitoring equipment are important considerations that must not be overlooked. Another vital aspect in this process is the pharmacokinetic and pharmacodynamic properties of the induction agent being utilized. Understanding these properties is essential for determining the most suitable dosing strategy. In clinical practice, outcomes can be categorized into underdosing versus overdosing, and also in terms of the choice between succinylcholine and etomidate. The implications of overdosing either of these agents raise some questions regarding their significance. While the risks associated with underdosing etomidate may not be substantial, it is imperative to follow its administration with appropriate sedation due to its brief duration of action. The primary concern lies with the underdosing of succinylcholine, which can lead to inadequate paralysis and unfavorable conditions for intubation. It is essential to understand the pharmacodynamics, clinical efficacy, and safety profiles of induction agents for effective patient management, especially in critical care settings. Two agents that are frequently discussed as primary induction options for rapid sequence intubation in acutely ill patients are ketamine and etomidate. Ketamine is classified as a dissociative anesthetic agent functioning as an N-methyl diaspartate receptor antagonist. It induces a cataleptic state rather than true unconsciousness. The onset of action for ketamine typically occurs within 30 to 45 seconds, and its clinical duration lasts approximately 15 minutes. The drug is metabolized in the liver into an inactive metabolite known as norketamine, which is then excreted by the kidneys. A significant characteristic of ketamine is its unique hemodynamic profile. While it primarily acts as a myocardial depressant, this effect is often counterbalanced by a secondary systemic sympathomimetic effect. This secondary action leads to the release of catecholamines and suppression of vagal tone, which can result in the preservation or even increase of systemic and pulmonary arterial blood pressure, heart rate, cardiac output, and cerebral perfusion pressure. These properties make ketamine an excellent induction agent for patients who are hypotensive. However, in cases where patients are catecholamine depleted, such as those experiencing prolonged hypotension or severe heart failure, the use of ketamine may heighten the risk of hemodynamic complications. This is because its sympathomimetic effects might not sufficiently counteract its myocardial depressant effects. Beyond its anesthetic properties, ketamine offers several additional benefits. For instance, it provides analgesia through NMDA receptor antagonism, which enhances opiate receptor activity. As a result, ketamine reduces the need for other analgesics and sedatives. Moreover, ketamine is known for its ability to preserve ventilatory drive while having bronchodilatory effects. This quality makes it particularly suitable for asthmatic patients as it dilates bronchial smooth muscle and stimulates pulmonary beta receptors. Historically, there were concerns about using ketamine in patients with increased intracranial pressure. Early studies suggested that it could raise intracranial pressure. However, more recent literature, especially concerning sedated and mechanically ventilated patients, indicates that ketamine does not increase intracranial pressure. In fact, it may have neuroprotective properties by maintaining mean arterial pressure and cerebral perfusion pressure. Importantly, ketamine does not increase cerebral oxygen consumption or reduce regional glucose metabolism. In 2011, the American College of Emergency Physicians reconsidered their position, removing head trauma as a relative contraindication for ketamine sedation. However, it is still relatively contraindicated in patients with central nervous system masses, abnormalities, or hydrocephalus. Lastly, it is important to note that ketamine does not inhibit adrenal function, distinguishing it from etomidate. Together, these benefits illustrate that ketamine is a versatile and valuable medication in various clinical contexts. Ordinary induction doses for ketamine typically range from 1 to 2 milligrams per kilogram. For patients who are depleted of catecholamines, a maximum dose of 1.5 milligrams per kilogram is recommended. Ketamine is also utilized as a continuous infusion for analgesia and sedation in the intensive care unit. The initial dosing starts at approximately 0.2 milligrams per kilogram per hour, with the potential to increase to 0.3 milligrams per kilogram per hour. Continuous infusion of ketamine has demonstrated effectiveness in increasing the time patients spend within their desired pain and sedation scores. It also reduces the reliance on other analgesics and sedatives. However, there are potential side effects associated with ketamine use. These may include increased oral secretions and emergence phenomena such as delirium, nightmares, and hallucinations. The use of prophylactic benzodiazepines to prevent these emergence reactions remains a debated topic, as such administration may increase the risk of respiratory depression. Ketamine and etomidate are often compared as induction agents because of their typically stable hemodynamic effects. Some observational studies suggest that ketamine may lead to a higher risk of post-induction hypotension, particularly in shock patients, while other research finds no significant difference in immediate hemodynamic responses between the two. Ultimately, regardless of the selected agent, maintaining optimal hemodynamic stability in the patient is essential. The impact of etomidate on mortality remains a critical and debated issue. Earlier systematic reviews and meta-analyses, including a Cochrane review published in 2015, found no conclusive evidence that etomidate increases mortality compared to other bolus induction agents. These studies often pointed out methodological limitations, heterogeneity among the data, and insufficient statistical power in studies that suggested a potential increase in mortality. More recent meta-analyses conducted between 2023 and 2024 have provided updated findings. A meta-analysis published in 2023 examined 11 randomized controlled trials involving a total of 2,704 patients. It concluded that etomidate was associated with an increase in mortality, with 23% of patients dying compared to 20% in the control groups. The analysis reported a risk ratio of 1.16 and a number needed to harm of 31, indicating that new harm may occur in 1 out of every 31 cases treated with etomidate. The authors noted a 98.1% probability that etomidate causes harm based on their data. This meta-analysis highlighted the EVK trial conducted by Matchett in 2022 as a significant recent, large-scale clinical trial contributing to these findings. Conversely, A Bayesian meta-analysis conducted in 2024 suggested that ketamine might reduce mortality compared to etomidate. The analysis indicated an 83.2% probability that ketamine leads to lower death rates, with 25% mortality in the ketamine group versus 27% in the etomidate group. However, the authors acknowledge that trial sequential analysis indicated the evidence remains inconclusive and emphasize the need for further research to reach definitive conclusions. The recent publication of the randomized trial of sedative choice for intubation offers important and current evidence to guide the selection of induction agents for rapid sequence intubation in critically ill adults. This study directly addresses one of the most debated topics in critical care medicine, whether to use etomidate or ketamine. Previous smaller studies and meta-analyses comparing these two drugs had produced conflicting results. Some suggested that ketamine might reduce the risk of death, while others found no significant difference. The trial was specifically designed as a large, practical, multi-center, randomized controlled trial to conclusively determine the impact of ketamine versus etomidate on mortality among critically ill adults undergoing emergency tracheal intubation. The rapid sequence induction trial was carried out at 14 different locations, including 6 emergency departments and 8 intensive care units across 6 United States medical centers. Investigators implemented a pragmatic study design, enrolling a total of 2,365 critically ill adults aged 18 years or older. Participants were randomized to receive either ketamine or etomidate for induction. Notably, patients whose primary diagnosis was trauma were excluded from the study. The patient cohort exhibited a high severity of illness. In the group receiving ketamine, 46.7% of patients had sepsis or septic shock, while in the group receiving etomidate, 47.5% had the same conditions. The median score on the Acute Physiology and Chronic Health Evaluation 2, a measure of illness severity, was 18 in both groups. The median dose of ketamine administered was 1.6 milligrams per kilogram of body weight, with an interquartile range of 1.4 to 2.0 milligrams per kilogram. For etomidate, the median dose was 0.28 milligrams per kilogram, with an interquartile range of 0.24 to 0.31 milligrams per kilogram. The primary outcome measured was death from any cause occurring in the hospital within 28 days. The results showed that using ketamine did not significantly reduce the rate of hospital death by this time point compared to etomidate. Specifically, 28.1% of patients in the ketamine group died in the hospital within 28 days compared to 29.1% in the etomidate group. This difference represented an absolute risk reduction of 0.8 percentage points, which was not statistically significant, with a 95% confidence interval ranging from -4.5 to 2.9 and a p-value of 0.65. These findings remain consistent across all sensitivity analyses and predefined subgroups, including the large subgroup of patients with sepsis or sepsis. The predefined secondary outcome was cardiovascular collapse during intubation. This was defined as either a systolic blood pressure dropping below 65 millimeters of mercury, the administration of a new or increased dose of vasopressors, or a cardiac arrest occurring between the time of induction and 2 minutes after intubation. Contrary to the expectation that ketamine would provide more hemodynamic stability, the trial found that cardiovascular collapse occurred more frequently in the ketamine group, affecting 22.1% of the patients. In comparison, 17.0% of patients in the etomidate group experienced this outcome. This represents a statistically significant absolute risk difference of 5.1 percentage points, with a 95% confidence interval ranging from 1.9 to 8.3. Specific indicators of hemodynamic instability also favored the use of etomidate. For instance, the receipt of a new or increased dose of vasopressors occurred in 21.3% of patients in the ketamine group compared to 15.9% in the etomidate group. Additionally, the median lowest systolic blood pressure was recorded at 112 millimeters of mercury in the ketamine group versus 118 millimeters in the etomidate group. Patients with sepsis or those experiencing a high severity of illness, indicated by an Apache 2 score greater than 20, showed the largest differences in cardiovascular collapse. The excess risk associated with ketamine in these groups was 9.7 and 10.7 percentage points, respectively. The results of the rapid sequence intubation trial represent a significant advancement in the medical education curriculum regarding the selection of induction agents. The trial challenges the long-standing debate over whether a single dose of etomidate causes clinically significant harm or increases mortality, especially in septic patients due to adrenal suppression. While earlier meta-analyses yielded mixed results, and some recent reviews suggested that etomidate might elevate mortality risk, with a relative risk of 1.16, the large-scale randomized controlled trial found no such difference. This finding supports current clinical practice guidelines issued by the Society of Critical Care Medicine in 2023, which state that there is no significant difference between etomidate and other induction agents concerning mortality or blood pressure instability. The perception that ketamine maintains better hemodynamic stability than etomidate, making it the preferred choice for patients who are hypotensive or septic, is also challenged by the trial's findings. The study demonstrated that cardiovascular collapse was more common among patients receiving ketamine, especially those with severe illness. This aligns with pharmacological knowledge that ketamine is inherently a myocardial depressant, and its stimulant effects on the sympathetic nervous system may be diminished or absent in patients who are catecholamine depleted, such as those experiencing prolonged hypotension or severe heart failure or shock. Conversely, etomidate is favored for its minimal cardiovascular effects, which typically do not significantly alter heart rate, blood pressure, systemic vascular resistance, or mean arterial pressure. These characteristics make it the preferred induction agent for patients who are hemodynamically unstable. The trial also emphasizes the importance of appropriate dosing. While ketamine is usually administered at 1 to 2 milligrams per kilogram, the study noted that actual body weight was used for dosing calculations. This approach may have increased the risk of complications, especially in obese patients, where pharmacokinetic principles recommend using lean body weight to prevent potential overdosing. Overdosing induction agents or underdosing neuromuscular blocking agents can compromise both the safety and effectiveness of rapid sequence intubation. Clinical practice implications suggest that although the trial found no difference in 28-day mortality, there was an increased risk of acute cardiovascular collapse associated with ketamine. These findings prompt a re-evaluation of the common practice of favoring ketamine as the default induction agent. The ongoing debate remains unresolved. Some literature continues to suggest that clinicians may use their preferred agent until definitive evidence emerges. Meanwhile, organizations such as the European Society for Emergency Medicine currently recommend combining ketamine with rocuronium, a practice sometimes referred to as rockketamine, due to their high therapeutic index and safety profile. The RSI trial suggests that while the use of ketamine does not offer a survival benefit over etomidate in non-trauma critically ill adults, it is associated with a higher incidence of acute hemodynamic deterioration during the critical peri-intubation period. This mandates a nuanced approach in medical education, emphasizing that induction agent selection must remain highly individualized based on the patient's specific characteristics and potential risks, prioritizing the avoidance of hemodynamic instability during airway management. The traditional view favored the use of ketamine for patients who were hemodynamically unstable, while skepticism was directed toward etomidate due to its transient suppression of the adrenal axis. However, the recent randomized trial comparing sedative choices for intubation in 2025 has prompted a need to re-evaluate these long-standing clinical beliefs. Regarding clinical guidelines, there remains some disagreement among major medical organizations, reflecting the continuously evolving nature of this debate. The Society of Critical Care Medicine published guidelines in 2023 indicating that there is no significant difference between etomidate and other induction agents concerning mortality, hypotension, or the requirement for vasopressors. The findings from the recent trial support a neutral stance on mortality while highlighting etomidate's advantageous profile in immediate hemodynamic stability. Conversely, the European Society for Emergency Medicine has traditionally recommended the rock-ketamine approach, which combines ketamine with rocuronium, citing its high therapeutic index and safety profile. Recent evidence suggesting increased cardiovascular collapse associated with ketamine indicates that a universal treatment strategy may need to be reconsidered, especially for patients experiencing profound shock. The ongoing discussion highlights the crucial importance of individualized assessment rather than relying on a standard approach with a default agent. Future research and educational efforts should focus on optimizing dosing strategies. There is evidence suggesting that induction agents are frequently dosed based on actual body weight rather than ideal or lean body weight. This practice may lead to overdosing in obese patients and contribute to hemodynamic instability. Therefore, investigating whether lower doses of ketamine, such as 0.5 milligrams per kilogram to 1.0 milligrams per kilogram, could provide a safer hemodynamic profile in critically ill patients remains an important priority. Additionally, future studies should explore alternative strategies such as delayed sequence intubation or pharmacologically assisted preoxygenation. These methods may offer improved safety margins for patients at high risk of cardiovascular collapse compared to standard rapid sequence intubation techniques. In terms of subpopulation analysis, while the rapid sequence intubation trial provided robust data for non-trauma patients, the best agent for trauma populations, particularly those suffering from traumatic brain injury and hypotension, continues to be a subject requiring specialized investigation. Ultimately, medical education emphasizes that selecting the most appropriate agent depends on a comprehensive evaluation of the patient's physiological condition. The primary goal is to avoid acute hemodynamic deterioration during the critical peri-intubation period. In the context of induction agents for rapid sequence intubation, propofol is a highly lipid-soluble phenolic derivative that acts as a GABA agonist, leading to sedation and unconsciousness. Propofol primarily exerts its sedative hypnotic effects through its interaction with the GABA receptor. This interaction is crucial for its mechanism of action, allowing for effective sedation of patients during medical procedures. One of the key characteristics of propofol is its rapid onset of action, which occurs within 10 to 50 seconds. This quick onset is a result of its high lipophilicity, enabling it to cross the blood-brain barrier with ease. Additionally, propofol has a short duration of action, lasting approximately 5 minutes. This brief duration is attributed to the rapid redistribution of the drug into peripheral tissues, as well as its swift metabolic clearance from the body. For dosing, a standard induction dose for healthy patients is typically between 1.5 and 2.5 milligrams per kilogram administered intravenously. For obese patients, it is important to use the actual body weight for dosing. This is because obesity is associated with an increased volume of distribution and a decreased elimination rate of the drug. In the case of elderly patients, it is advisable to consider lower doses, ranging from 50 to 100 milligrams. This adjustment is necessary due to their reduced rate of elimination and smaller central volume of distribution. Regarding metabolism, propofol undergoes hepatic metabolism, resulting in the formation of water-soluble sulfate and glucuronide conjugates. This metabolic pathway makes propofol suitable for use in patients who have hepatic or renal impairment. It is important to note that propofol does not provide analgesic properties, meaning it should not be considered an analgesic agent in clinical practice. Hypotension and bradycardia are notable complications associated with the use of propofol. This agent can lead to a decrease in systemic blood pressure and exert a negative inotropic effect. The potential for hypotension and bradycardia results from the drug's properties as a calcium channel blocker and a beta-adrenergic receptor antagonist. These characteristics contribute to a reduction in sympathetic nervous system activity. Certain risk factors heighten the likelihood of experiencing exaggerated hypotension when propofol is administered. Caution is particularly important for patients who are volume depleted, have existing hypotension, or demonstrate a reduced ejection fraction. The concurrent use of opioids, undergoing abdominal surgery, having a frail physical state, being female, and being elderly are all factors linked with an increased hypotensive response. The use of propofol as an induction agent has been identified as a risk factor for cardiovascular collapse during the peri-intubation period. A recent large-scale cohort study determined that induction with propofol significantly increases the risk of hemodynamic complications in patients who are critically ill. Due to its pronounced hypotensive effects, particularly when combined with opioids, many medical guidelines discourage the use of propofol in critically ill patients unless more suitable alternatives are unavailable. In cases involving trauma patients who present normal to elevated blood pressure and show concerns about elevated intracranial pressure, propofol is recommended for post-intubation sedation because it can effectively lower the mean arterial pressure. However, in patients with hypotension, alternative sedatives such as midazolam and fentanyl are preferred due to their minimal impact on hemodynamics. One beneficial aspect of propofol is its ability to decrease intracranial pressure. In a study involving patients who suffered head injuries, administration of a propofol bolus resulted in a mean decrease in intracranial pressure of 14 millimeters of mercury. This response renders propofol a suitable choice for inducing anesthesia in patients with elevated intracranial pressure. Additionally, propofol may provide neuroprotective benefits, especially in cases of mild traumatic brain injury. Bronchodilation is one of the properties of propofol, which exhibits mild bronchodilating effects. This characteristic makes it a suitable induction agent for patients who experience bronchospasm. However, it is essential to be aware of propofol infusion syndrome, commonly referred to as PRE. This syndrome is primarily associated with prolonged infusions that last longer than 72 hours and involve high concentrations exceeding 75 micrograms per kilogram per minute. PRE can present with significant risks, including worsening metabolic acidosis, hypertriglyceridemia, and hypotension, often accompanied by an increased need for vasopressors and the potential for arrhythmias. The mortality rates associated with this syndrome can reach as high as 33%. Nevertheless, the risk of developing PRE is not a concern when propofol is used solely as an induction agent. Patients may also experience pain at the injection site when receiving propofol. This discomfort can be alleviated by employing lidocaine, utilizing a larger peripheral vein for administration, or opting for central venous administration. Regarding allergies, it is important to note that propofol is formulated as an oil-water emulsion that contains soybean oil and egg lecithin. Although it has historically been contraindicated for individuals with egg allergies, it is critical to understand that major allergens from eggs are found in the egg white, while the lecithin utilized in propofol is derived from the egg yolk. Anaphylactic reactions to propofol are rare and are believed to be due to the presence of isopropyl or phenyl groups in the formulation rather than the lipid component itself. Including this, some generic formulations of propofol may contain sulfite preservatives, which can also lead to allergic reactions in sensitive individuals. In terms of pregnancy, propofol is regarded as the drug of choice for induction in pregnant women, classified as a Category B drug. Overall, propofol is recognized as a rapid-acting induction agent with a short duration of action. Its ability to lower intracranial pressure and its safety profile make it particularly valuable in patients experiencing bronchospasm or in pregnant individuals. However, one must be cautious of its significant hypotensive effects, especially in hemodynamically unstable or critically ill patients. In such cases, alternative induction agents like Etomidate or Ketamine are often preferred due to their more neutral effects on hemodynamics. Thus, propofol's role as a preferred induction agent is less pronounced in critical care environments compared to these alternatives. Barbiturates, such as thiopental and methotrexate, have historically served as common agents for induction in rapid sequence intubation. Nonetheless, their contemporary application has significantly diminished. This reduction is chiefly ascribed to the widespread acceptance of propofol and issues related to drug shortages. In the past, barbiturates were widely used for induction purposes. However, the rise of propofol, along with the challenges stemming from drug shortages, has caused a dramatic decline in the use of these substances. It is noteworthy that thiopental is currently unavailable in the United States, while methotrexate remains as a short-acting barbiturate alternative. The mechanism of action of barbiturates involves their role as agonists on gamma-aminobutyric acid receptors. At lower concentrations, these agents enhance the activity of gamma-aminobutyric acid by reducing its dissociation from the receptor. In contrast, at higher doses, they directly stimulate the gamma-aminobutyric acid receptor. Barbiturates are metabolized in the liver, and methotrexate, in particular, is recognized for having no active metabolites. The typical dosage for the induction of methotrexate is 1.5 milligrams per kilogram. The hemodynamic profile of methotrexate presents several common side effects, including respiratory depression, venodilation, and myocardial depression. It is prudent to avoid the use of methotrexate in patients who are hypotensive, especially when alternatives such as ketamine or etomidate are available. A retrospective study comparing the effects of methotrexate and etomidate during intubation found no significant differences in their hemodynamic impacts. In terms of cerebral effects, methotrexate can reduce the demand for metabolic oxygen in the brain, lower intracranial pressure, and decrease cerebral blood flow. However, caution is warranted with this agent in patients who have suffered traumatic brain injuries because it can potentially lead to hypotension. Methotrexate may also trigger histamine release, which can worsen reactive airway disease. Additionally, patients might experience excitatory symptoms that include hiccups and twitching. Given its alkaline pH, complications such as distal thrombosis and tissue necrosis might occur if methotrexate is administered intraarterially or due to extravasation. In the broader context of induction agents for rapid sequence intubation, selecting the most suitable drug is vital. This selection process must take into account patient-specific factors, as well as the distinct pharmacological characteristics of each agent. Although barbiturates like thiopental and methotrexate have been historically used, their relevance has decreased with the emergence of agents that possess varying safety profiles alongside the challenges presented by drug availability. In the context of rapid sequence intubation and the selection of induction agents, midazolam, a type of benzodiazepine, is recognized as one of the commonly used options. Its role and preference in clinical settings have evolved over time. Midazolam is a fast-acting benzodiazepine that serves as a sedative and hypnotic. The mechanism of action involves the agonism of the gamma-aminobutyric acid receptor complex, which results in central nervous system depression. Due to its high lipophilicity, midazolam can rapidly cross the blood-brain barrier. However, it also undergoes rapid and extensive redistribution, which contributes to its short half-life. The drug offers anxiolytic, amnestic, sedative, hypnotic, and anticonvulsant effects. However, it notably lacks analgesic properties. Its amnestic effects may persist beyond the duration of its sedative effects. When used for induction, the typical dosage of midazolam ranges from 0.1 to 0.3 milligrams per kilogram when administered intravenously. Following an intravenous bolus, the onset of action is usually between 1 to 2 minutes. Nonetheless, when used as an induction agent alone, the onset may extend up to 5 minutes, which results in an incomplete loss of consciousness. This delay is regarded as unacceptable in rapid sequence intubation scenarios. The co-administration of opioids can accelerate the onset of action to approximately 90 seconds. In terms of metabolism, midazolam is processed in the liver and produces an active renal metabolite known as 1-hydroxymidazolam. The clinical effects of midazolam may be prolonged in elderly patients or individuals who have impaired renal or hepatic function. Midazolam can lead to a decrease in systemic vascular resistance and myocardial depression, resulting in hypotension, particularly when used together with other cardiopulmonary depressants such as opioids. Due to its effects on hemodynamics, midazolam is often less preferred than agents like ketamine. Furthermore, respiratory depression is a potential side effect, especially when combined with medications like fentanyl. When used for prolonged periods in the intensive care unit, midazolam can accumulate in tissues, which may delay awakening. This can contribute to prolonged coma, increased days on a ventilator, and extended stays in the intensive care unit when compared to propofol. Abruptly discontinuing midazolam after extended exposure may lead to withdrawal symptoms. These symptoms can include anxiety, agitation, tremors, headaches, sweating, insomnia, nausea, vomiting, myoclonus, muscle cramps, hyperactive delirium, and in some cases, seizures. In terms of overall clinical considerations, midazolam has a history of use and certain pharmacokinetic properties that can be beneficial for treating anxiety. However, its application as a primary agent for rapid sequence induction, especially in critically ill or hemodynamically unstable patients, is often approached with caution. This hesitance relates to concerns about the drug's dose-dependent hypotensive effects and its potential for causing prolonged sedation or delayed awakening. Modern guidelines and recent evidence frequently favor alternatives such as ketamine or etomidate due to their more neutral impacts on hemodynamics during induction. Additionally, non-benzodiazepine sedatives are recommended for post-intubation sedation in the intensive care unit to enhance patient outcomes. Nevertheless, midazolam continues to be an important medication for managing anxiety, seizures, or withdrawal from alcohol and benzodiazepines in patients in the intensive care unit. It can also be employed when deep sedation, amnesia, or combination therapy is deemed necessary. In the dynamic field of medical education, it is essential to have a comprehensive understanding of central nervous system modulation, particularly concerning central nervous system excitation, and its pharmacological management during rapid sequence intubation. This content outlines the intricate balance of key neurotransmitters, the crucial goals of rapid sequence intubation, the multifaceted factors that influence the selection of induction agents, and a detailed review of commonly used pharmacological agents. Central nervous system excitation signifies heightened neuronal activity that is regulated by the interplay between excitatory and inhibitory neurotransmitter systems. Gamma-aminobutyric acid, the primary inhibitory neurotransmitter, is synthesized from glutamate and mediates inhibition through ionotropic gamma-aminobutyric acid A and C receptors, which increase chloride influx to produce fast inhibitory postsynaptic potentials, and metabotropic gamma-aminobutyric acid B receptors, which alter potassium and calcium influx for slower inhibition. Barbiturates and benzodiazepines enhance gamma-aminobutyric acid A receptor-mediated inhibition, contributing to their anticonvulsant and sedative effects. Glutamate, the principal excitatory neurotransmitter, accounts for approximately 75% of central nervous system excitatory neurotransmission. It acts on ionotropic receptors, including alpha-amino-3-hydroxy-5-methyl-4 isoxazolipropionic acid kinase and N-methyl diaspartate receptors, as well as on metabotropic glutamate receptors. The activation of alpha-amino-3-hydroxy-5-methyl-4 isoxazolipropionic acid and kinase receptors primarily causes fast sodium influx, whereas N-methyl diaspartate receptor activation allows the influx of calcium and sodium. This process requires both glutamate and glycine binding, in addition to depolarization to remove a magnesium block. N-methyl diaspartate receptor antagonists are utilized for various therapeutic purposes, including chronic pain management. Maintaining the balance between gamma-aminobutyric acidergic inhibition and glutamatergic excitation is vital for normal central nervous system function. In the context of rapid sequence intubation, the objective is to induce profound central nervous system depression. While gamma-aminobutyric acidergic drugs directly enhance inhibition, ketamine achieves central nervous system alteration by antagonizing excitatory glutamate receptors. The primary objectives of sedation during rapid sequence intubation are to ensure that the patient is unaware of the procedure, and to facilitate successful endotracheal intubation. Sedation and analgesia are mandatory during such invasive procedures, and a sedative or induction agent must always precede a neuromuscular blocking agent in responsive patients. The selection of an induction agent for rapid sequence intubation is a comprehensive process that is influenced by patient-specific characteristics, underlying medical conditions, and the pharmacokinetic and pharmacodynamic properties of available drugs. For hemodynamically unstable patients, etomidate is often favored due to its minimal cardiovascular effects. Ketamine, known for its sympathomimetic effects, can increase blood pressure and heart rate, making it suitable for hypotensive patients, including those with asthma. While propofol allows for a rapid return to mental status, it can lead to significant decreases in blood pressure and adverse inotropic effects, necessitating caution in unstable patients. The shock index may help predict hemodynamic response to ketamine, with patients who have a high shock index more prone to hypotension due to depleted catecholamine stores. Airway considerations are particularly important in the selection of induction agents. Propofol and ketamine are preferred for patients with asthma or bronchospasm due to their bronchodilator properties, while barbiturates may induce histamine release. When considering underlying medical conditions, ketamine and propofol are well suited for patients with asthma due to their bronchodilatory effects. In patients with seizures, etomidate may increase the risk of seizures by enhancing electroencephalogram activity in epileptogenic foci. For patients with elevated intracranial pressure, propofol, barbiturates, and etomidate all decrease intracranial pressure and cerebral metabolic oxygen demand, making them appropriate choices. Historically, ketamine was avoided in these cases, but recent evidence in sedated and mechanically ventilated patients suggests that it does not increase intracranial pressure and may be neuroprotective by maintaining cerebral perfusion pressure. Ideal induction agents for rapid sequence intubation have rapid onset and short duration. Parenteral anesthetics typically have lipophilic properties, allowing for rapid entry into the central nervous system. Ketamine's large volume of distribution and rapid clearance support its use in continuous infusion. Other considerations that play a role in agent selection include potential side effects, such as pain on injection with propofol and myoclonic jerks or adrenocortical suppression with etomidate drug availability, and the specific needs for rapid sequence intubation, especially in patients at risk of aspiration. Specific induction agents are crucial in managing unconsciousness during medical procedures. Among these, etomidate is an imidazole-derived sedative hypnotic that stimulates GABA receptors, leading to rapid unconsciousness. The typical dosing for etomidate ranges from 0.2 to 0.3 milligrams per kilogram. In cases where patients are hemodynamically unstable, lower doses are recommended. Etomidate has several advantages. It has minimal cardiovascular effects, which helps to preserve heart rate and blood pressure. It is also considered cerebroprotective because it reduces intracranial pressure, cerebral blood flow, and oxygen consumption while maintaining cerebral perfusion pressure. However, etomidate does not provide analgesic properties, and common adverse effects include myoclonic jerks and pain upon injection. A significant concern with this agent is its transient and reversible inhibition of 11-beta-hydroxylase, an enzyme essential for cortisol production. This inhibition can last up to 72 hours. Although biochemical suppression is observed, meta-analyses often show no conclusive evidence linking a single dose of etomidate to increased overall mortality or healthcare resource utilization. Prophylactic corticosteroids are not recommended in this context. Ketamine, another induction agent, is a dissociative anesthetic and NMDA receptor antagonist. It induces a cataleptic state instead of true unconsciousness, with an onset time of 30 to 45 seconds and duration of around 15 minutes. The recommended dosing for ketamine is between 1 to 2 milligrams per kilogram, with a maximum of 1.5 milligrams per kilogram for catecholamine-depleted patients. One of the key advantages of ketamine is that it preserves or increases systemic and pulmonary arterial blood pressures, heart rate, and cardiac output, due to its sympathomimetic effects, making it especially suitable for hypotensive patients. Ketamine also provides analgesia through NMDA receptor antagonism, exhibits bronchodilatory effects, preserves ventilatory drive, and does not inhibit the adrenal axis. Recent literature suggests that ketamine does not increase intracranial pressure in sedated, mechanically ventilated patients and may even be neuroprotective. However, it also has disadvantages, including potential for increased oral secretions and emergence phenomena such as delirium, nightmares, and hallucinations. Another agent is propofol, a highly lipid-soluble GABA agonist that causes rapid sedation and unconsciousness. Its onset time ranges from 10 to 50 seconds, and the duration is about 5 minutes. The standard induction dose for propofol is between 1.5 to 2.5 milligrams per kilogram. The advantages of propofol include its rapid onset and offset, the ability to decrease intracranial pressure, potential neuroprotective effects, mild bronchodilating properties, and its safety for induction in pregnant women. However, propofol has significant dose-dependent hypotension and bradycardia due to its negative inotropic and vasodilator effects. This is particularly risky for volume-depleted or hypotensive patients. Moreover, propofol lacks analgesic properties and commonly causes pain on injection. A rare, but severe complication associated with prolonged and high-concentration propofol infusions is propofol infusion syndrome. Historically, barbiturates such as thiopental and methotrexate were commonly used, but are now less utilized, primarily due to the availability of propofol and drug shortages. Barbiturates act as GABA agonists, with typical dosing for methotrexate being 1.5 milligrams per kilogram. These agents decrease cerebral metabolic oxygen demand, intracranial pressure, and cerebral blood flow. On the downside, they can cause respiratory depression, venodilation, myocardial depression, histamine release, which may exacerbate reactive airway disease and excitatory symptoms. Thus, barbiturates should be avoided in hypotensive patients. Midazolam is a fast-acting benzodiazepine and GABA receptor agonist, which provides anxiolytic, amnestic, sedative, hypnotic, and anticonvulsant effects. The induction dose for midazolam is between 0.1 to 0.3 milligrams per kilogram. A notable disadvantage of midazolam is that it has a slow onset when used alone for rapid sequence intubation, taking up to 5 minutes, which is insufficient for a rapid loss of consciousness. Midazolam also lacks analgesic properties and can lead to dose-dependent hypotension and respiratory depression, especially when combined with opioids. Prolonged use of midazolam may result in delayed awakening and withdrawal symptoms. As a result, its role as a primary induction agent in rapid sequence intubation has diminished in favor of agents with more neutral hemodynamic profiles. Recent evidence in 2025 is harnessing the shift back to Etomidate, becoming the first-line induction agent for RSI.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.